Hello, everybody. Today's topic of discussion is Guillain-Barré syndrome. So, Guillain-Barré syndrome was described by Guillain-Barré and Stoll in 1916 as an acute flaccid paralysis with areflexia and elevated spinal fluid protein without leukocytosis. It is the most common cause of rapidly progressive weakness due to peripheral nerve involvement with annual incidence of 0.6 to 2 cases per 1 lakh population. For decades, GBS has been viewed as an acute inflammatory demyelinating polyradiculopathy affecting nerve roots and the cranial and peripheral nerves of unknown cause that occurs at all ages. In past 30 years, the recognition of primary axonal form of GBS has broadened the spectrum of GBS to include the demyelinating form and axonal form. Acute motor axonal neuropathy, that is AMAN, acute motor sensory axonal neuropathy, that is AMSAN, as well as Miller-Fisher syndrome. Now we will see the clinical features in acute inflammatory demyelinating polyradiculoneuropathy. GBS often occurs in 2 to 4 weeks after flu-like or diarrheal illness caused by a variety of infectious agents, including cytomegalovirus, Epstein-Barr and herpes simplex virus, mycoplasma, chlamydia, and Campylobacter jejuni. More recently, Zika virus and SARS-CoV-2 has been reported in association with GBS. It can also be early manifestation of human immunodeficiency virus infection before development of an immunosuppressed state. So Lyme disease may rarely produce a syndrome of polyradiculopathy, remnants of GBS. Other antecedent events include immunization, general surgery, renal transplantation, Hodgkin disease, and systemic lupus erythematosus. The illness is held by presence of dysthesias of feet or hand or both. The major feature is weakness that evolves rapidly and classically has been described as ascending from the leg to arm and in severe cases to respiratory and bulbar muscles. Weakness may, however, start in cranial nerve or arm and descend to the legs and start simultaneously in arm and legs. Proximal muscles are often involved early in the course of disease. Approximately 80% of patients reach nadir of the clinical course by 2 weeks into illness and 97% by 1. The progression of symptom beyond the 4 weeks but arresting within the 8 week has been termed as subacute inflammatory demyelinating polyneuropathy, whereas the progression beyond 2 months is designed as chronic inflammatory demyelinating polyneuropathy, a disorder with natural history different from GBS. Up to 16% of the patient with chronic inflammatory demyelinating polyneuropathy may present acutely as GBS. Those who continue to progress to chronic inflammatory demyelinating polyneuropathy more often have pronounced sensory signs and less likely to have facial weakness, autonomic involvement, and a preceding infectious illness or require mechanical ventilation. A small percentage of patients, up to 6%, have recurrent GBS, and these patients are often younger than 30 years, have milder symptoms, and more often have Miller-Fisher syndrome. Several years often pass between the episodes, differentiating them from patients with treatment-related fluctuation, where worsening occurs within the first 8 weeks of disease onset after initial improvement and stabilization. The extent and distribution of weakness in GBS are variable. Within few days, the patient may become quadriparetic and become respiratory dependent, or the illness may take benign course and after progression of 3 weeks produces only mild weakness of face and limbs. Now regarding physical finding, The typical case of moderate severity, the physical examination discloses the symmetrical weakness in proximal and distal muscle group with attenuation or loss of deep tendon reflexes. In the early stage of illness, there is no muscle wasting or fasciculation. If attack is particularly severe and axons are interrupted, muscle undergo atrophy and scattered fasciculation may be seen after number of months. Sensory loss is usually mild, although variant of GTS is described in which sensory loss is widespread, symmetric, and profound. Respiratory muscles are often involved, and 25% to 30% of patients require ventilator assistance within 18 days after onset. There is often mild to moderate bilateral facial weakness. Mild weakness of tongue and the muscles of deglutination may also develop. Ophthalmoparesis from extraocular motor nerve involvement is unusual in typical patient with GPs. In the Miller-Fisher variant, however, ophthalmoplegia occurs in combination with ataxia and areflexia with little limb weakness. Pupillary abnormalities have been noted in GBS and in Miller-Fisher variant. Papilledema is rare. Autonomic nervous system disturbances occur in up to two-thirds patient and potentially lethal. Autonomic dysfunction takes the form of excessive or inadequate activity of sympathetic or parasympathetic nervous system or both. Common findings include cardiac arrhythmias, for example, persistent sinus tachycardia, bradycardia, ventricular tachycardia, atrial fibrillation, atrial flutter, asystole, orthostatic hypotension, and transient or persistent hypertension. Other changes include transient bladder paralysis, increase or decreased sweating, and paralytic ileus. The pathophysiology of these changes is not completely understood but may be caused by inflammation of thinly myelinated and unmyelinated axon of the peripheral autonomic nervous system. The neuropathy predominantly affecting peripheral autonomic nervous system has been described that may have pathogenesis similar to that of the GBS. Hypertension from dysautonomia may be responsible for association of posterior reversible encephalopathy syndrome seen in some patients with the GBS. Now the clinical features of axonal form. Like AIDP, the axonal forms present with the rapidly progressive weakness, areflexia, and albuminocytological dissociation, but differ in the following ways. Patient with the AMAN lack sensory abnormalities, and most often children and young adult in northern China, Mexico, Japan develop AMAN during summer months. Many have experienced antecedent Campylobacter jejuni infection. Patients with AMAN also have more rapid progression to their nadir, but recovery times are quicker and similar to AIDP for some, whereas other patients have protracted recovery. AMSAN is characterized by sensory and motor deficit and long time to recovery. In series by Fisby et al., these patients had much shorter time to peak severity, had more severe symptoms with more than half requiring mechanical ventilation, and had inexcitable motor nerve, and most had poor recovery. Now, regarding lab features, most characteristic lab features of GBS are abnormal CSF profile with albuminocytological dissociation, which is characterized by elevated protein without leukocytosis and abnormal nerve conduction studies. CSF examination is helpful for supporting diagnosis of GBS. Although the CSF protein may be normal in about 50% if tested in first 3 days, by 1 week into illness, CSF protein is elevated in 79% of patients, sometimes to level as high as 1 gram per day. Rarely, even several weeks after onset of GBS, the CSF protein remain normal and the diagnosis must rest on the presence of otherwise typical clinical feature. The cell count is normal for most patients with GBS, but mild pleocytosis of 10 to 50 cells per microliter may be seen in 15% of patients. The presence of pleocytosis should raise suspicion for HIV, Lyme's disease, cytomegalovirus, carcinomatous, or lymphomatous meningitis. CSF glucose is expected to be normal. Electrodiagnostic studies in AIDP typically shows non-length dependent motor and sensory demyelinating polyneuropathy with slowing of motor nerve conduction velocities, increase in distal motor latencies, and evidence of temporal dispersion and partial conduction block along motor field. FFs are absent and have prolonged latencies, and sensory responses are reduced or absent. The amplitude of evoked motor responses may be reduced because of axonal loss or distal nerve conduction block, and responses are frequently dispersed because of differential slowing along still conducting axon. Because pathologic process may be restricted to spinal nerve root and proximal nerve segment, routine nerve conduction studies early in the course of neuropathy may be normal initially. In such a cases, H reflexes are often absent and F responses are abnormal. Thus, this abnormal late response, along with the sural sparing and reduced or absent median sensory response, are characteristic of early GBS. Early in the course of GBS, needle electrode examination of voluntary contraction of weak muscle demonstrated reduced motor unit potential recruitment because of nerve conduction block. Several weeks later, needle examination of weak muscle reveal active denervation changes with fibrillation potential and positive sharp waves reflecting motor axonal loss that is often part of AIDP and central to the pathogenesis of AMAN and AMSA. For patients with severe axonal form of GBS, AMSA motor and sensory nerve may be electrically inexcited. In AMAN, the motor responses are low and absent, whereas the conduction velocities and sensory responses are not. Motor conduction block without temporal dispersion may be seen in AMAN due to reversible conduction failure at nodes of Wrangler, and this may lead to confusion in correctly classifying axonal versus demyelinating subtype on first presentation. Serial electrodiagnostic studies may help diagnose the correct subtype and therefore more accurately predict the diagnosis. The electrodiagnostic finding of Miller-Fisher syndrome are indicative of sensory neuropathy with reduced or absent sensory response throughout despite normal motor status. Except for mild increasing ESR, hematological studies are not. Some electrolytes may disclose hyponatremia, sometimes to marked degree because of inappropriate secretion of ADH, antidiuretic hormone, caused by disturbances of peripheral volume receptor. There may be evidence of previous viral or mycoplasma infection, such as lymphopenia or atypical lymphocytes. In some cases, the evidence of recent viral infection may be sought by measuring antibodies titer against specific infectious agent, especially cytomegalovirus, Epstein-Barr virus, and Campylobacter jejuni. In selected cases, screening for HIV infection should be undertaken. Approximately 90% of patients with Miller-Fisher syndrome have high titers of GQ1B antibodies, and their presence confirms diagnosis of this disorder. Antibodies to GM1, GD1A, G1, GM1B, and GalNAc GD1A are associated with axonal form of GBS. Anti-GBM antibody are reported among 10% to 42% of patients with AMA. And the magnetic resonance imaging studies may show enhancement of spinal nerve root or cauda equina in 83% to 92% of patients with GBS, in addition to the enhancement of cranial nerves. This may aid in diagnosis where electrodiagnostic studies or CSF studies are equivalent. Now we'll see what are the differentials. So myasthenia gravis is one of the differential diagnosis for GBS, and the distinguishing features are reflexes will be spared in myasthenia gravis, ocular weakness will be predominant, and there will be the positive response to endorphin. Then botulism, the predominantly bulbar involvement will be there. Autonomic abnormalities can be seen, and EMG showed normal velocity, low amplitude, and the incremental response. Then the next differential is tick paralysis. It has rapid progression and tick will be there. Then shellfish poisoning. It also has rapid onset, follow consumption of mussels and clam. Then toxic neuropathies. So EMG showed axonal loss. Then organophosphorus poisoning, which showed acute cholinergic reaction toxicity. Then porphyric neuropathy showed mental disturbances and abdominal pain, and diphtheric neuropathy. It showed prior pharyngitis, slower evaluation, palatal accommodation paralysis, and myocarditis. Then poliomyelitis, which is characterized by weakness, pain, tenderness, preserved sensation, and CSF showed protein and cell counts elevated. Then West Nile virus neuroinvasive disease, which is associated with fever, meningitis, encephalitis, asymmetric weakness, and CSF showed protein and cell count elevated. Then acute flaccid paralysis showed asymmetric weakness, arm more than the leg. MRI spinal cord shows T2 hyperintensity of gray matter. Then periodic paralysis, reflexes were normal, cranial nerves and respiration spared, abnormal serum potassium concentration. Then critical illness myopathy, there will be sepsis and multi-organ failure of more than 2 weeks, and EMG will show the axonal loss. Then acute myopathy of intensive care is characterized by the tetraparesis and areflexia, follows the prolonged treatment with the neuromuscular blocking agent and corticosteroid. Then it is associated with trauma, status epilepticus, and organ transplant. Then regarding pathogenesis, so acute inflammatory demyelinating polyneuropathy is caused by immunologically mediated demyelination of peripheral nervous system. It is likely that humoral and cellular component of immune system precipitate in macrophage-induced peripheral nerve demyelination. Although histological appearance of AIDP resembles the experimental autoimmune neuritis, in which predominantly T-cell mediated immune response is directed against peripheral nerve myelin protein, the role of T-cell mediated immunity in AIDP remains unclear. The findings of complement activation marker along the outer surface of Schwann cell has led to speculation that complement fixing antibodies directed towards as yet unidentified epitope on outer surface of Schwann cell play a role in AID. Axonal degeneration may occur, especially in severe cases, as a bystander where there is intense inflammation. In axonal subtype, the immune response is targeted to different portion of peripheral nerve, the axon. There is strong evidence that antibodies directed against ganglioside antigen on axonoma target macrophage to invade the axon at nodes of red. The rapid decline and subsequent quick recovery of many patients with AMAN suggested that severe axonal degeneration of nerve root is unlikely to be pathological basis for this disorder. Proposed mechanism include physiological block of the conduction and very distal degeneration and subsequent regeneration of intramuscular motor nerve terminus. The presence of antiganglioside antibodies like GM1, GD1A, G1B, and GAL-NC GD1A antibodies in axonal GPS and GQ1B in Miller-Fisher syndrome, and findings of ganglioside-like epitope on some strain of Campylobacter jejuni have led to the concept of molecular mimicry, in which immune attacks occur on the epitope shared by the nerve fiber and infectious organism as possible mechanism for GBS, especially Campylobacter jejuni associated GBS. There is increasing evidence that anti-GM1 antibody blocks sodium ion channel at nodes of Renvier and transiently producing conduction failure. In addition, Koga et al. Found evidences that genetic polymorphism of Campylobacter jejuni determine the production of specific autoantibodies and correlate with clinical presentation of GBS, possibly through modification of host mimicking molecules. Now, regarding pathology, pathological studies of the nerve from patient dying with GPS have usually shown infiltration of endonucleum by mononuclear cell with the prediction of perivenular distribution. The inflammatory process occurs throughout the length of the nerve from its origin at root level to distal ramification of nerve twin in substance of muscle fiber. The brunt of inflammatory process, however, occur at more proximal level and takes the form of discrete foci of inflammation. Macrophage invade the intact myelin sheath and denude the axon. Patients with prominent axonal loss are least likely to recover fully and may live with functionally significant residual motor weakness. In Aman and Amsan, there is evidence of Wallerian-like degeneration of nerve fiber, but only minimal inflammation or demyelination. Macrophages are seen within periaxonal space, especially at the nodes of Renvier, displacing or surrounding the axon and leaving the myelin sheath intact. Abnormalities are seen in nerve roots and peripheral nerves. In those with AMSAM, motor and sensory fibers are affected, whereas only motor fibers are affected in AMAN with sparing of sensory fibers. Now, regarding management, the three major treatment issues with GBS are controlling respiration and deciding when to intubate the patient, recognizing and managing autonomic dysfunction, and determining which patients are candidate for plasmapheresis or intravenous immunoglobulin. So patients with the GBS require the excellent nursing care, medical management, and emotional support. The respiratory failure is the most serious complication of GBS. Need for ventilator cannot be reliably predicted on the basis of extent of weakness. However, patients who are highly likely to require mechanical ventilation are those with rapid disease progression, bulbar weakness, autonomic dysfunction, and bilateral facial weakness. Erasmus GPS respiratory insufficiency score, that is IGRIS, is the scale used to predict the risk of respiratory failure during first week of admission. Classical clinical characteristic including time between onset of weakness and admission, severity of weakness as measured by medical research counseling some score, and presence of facial and bulbar weakness are used to derive a score from 0 to 7 corresponding to 1% to 90% probability of respiratory insufficiency in first week. This may assist in deciding if patient needs ICU level of care. Patient must be followed up carefully with measurement of maximum inspiratory pressure, force vital capacity until weakness has stopped progressing. So respiratory insufficiency can be anticipated and managed appropriately. Roper and CAN 16 suggest the intubation if any of the following criteria is met, like mechanical ventilatory failure with reduced expiratory vital capacity of 12 to 15 ml per kg, oropharyngeal paralysis with aspiration, falling vital capacity over next 4 to 6 hours, and clinical signs of respiratory fatigue at vital capacity of 15 ml per kg. Lawn et al. Found that respiratory factors to be highly associated with progression of respiratory failure, that is vital capacity of less than 20 ml per kg, then maximum inspiratory pressure less than -30, maximum expiratory pressure less than plus 40, or reduction of more than 30% of vital capacity, maximum inspiratory pressure, and maximum expiratory pressure in 24 hours. Elective intubation may be considered for these patients at particularly high risk of progression to respiratory failure. Intubation should be accomplished with the soft cuff low pressure endotracheal tube. The decision to delay tracheostomy for 7 to 10 days is likely to avoid operation for as many as one third of the patient who improve rapidly and can be extubated after first few days. After at 1 week, however, several factors are associated with high risk of prolonged mechanical ventilation, including severe deltoid paresis, unexcitable nerves on nerve conduction studies, or axonal subtype of GBs. These patients may be considered for tracheostomy or to prevent vocal cord and tracheal damage. The nursing and mechanical team may also be aware of many autonomic nervous system disturbances that can occur. Fluctuating blood pressure with transient hypertensive episode, sometimes associated with extreme degree of agitation that may be present. Other manifestation of sympathetic nervous system overactivity include sudden diaphoresis, general vasoconstriction, and sinus tachycardia. Evidence of underactivity of sympathetic nervous system include presence of marked postural hypotension, high sensitivity to the dehydration and sedative hypnotic agent. Excessive parasympathetic nervous system activity is reflected in facial flushing associated with feeling of generalized warmth and bradycardia. Electrographic changes consisting of ST and T wave changes also occur. Therefore, careful monitoring of blood pressure, fluid status, cardiac rhythm is absolutely essential to manage the patient with GBS. Hypertension may be managed with short-acting alpha-adrenergic blocking agent and hypotension with fluids, bradyarrhythmias with atrophy. As noted earlier, hyponatremia may occur and is probably best managed by free water restriction. A bedridden patient needs to be turned frequently to avoid the development of pressure sores. Paralyzed limb require the attention of physiotherapist so that passive limb movement can be carried out and contracture prevented. The ICU team needs to be aware of potential for development of compression neuropathies, and insulating pads should be placed over unusual susceptible site like elbows and head of the fibula. Pain may be treated with the standard doses of analgesic, but they do not often provide adequate relief. Gabapentin or carbamazepine is particularly helpful for treating the pain in acute phase, and when disabling, epidural morphine may be necessary. Deep venous thrombosis and pulmonary embolism are ever presenting dangers for bedridden patient with immobilized vein, and for this patient, in addition to physical therapy, pharmacological venous thromboembolism prophylaxis and sequential mechanical compression devices are recommended. A number of multi-center studies showed that plasma exchange has a beneficial effect on course of illness if started within 30 days of symptom, even in those patients with severe poor prognostic sign. Patients treated with plasma exchange are able to walk on average 1 month earlier than the untreated patient. Respiratory dependent patients so treated walk 3 months sooner than those who do not receive plasma exchange. The GBS study group guideline recommended exchanging 200 to 250 ml plasma per kg body weight over 7 to 14 days in 3 to 5 days. 5% salt poor albumin is used as replacement fluid. Then fresh frozen plasma should be avoided because of risk of hepatitis, HIV, and this occasional pulmonary edema. It is important to keep in mind, however, there are also risks with albumin, including bleeding, thrombosis, and infection, owing to the loss of coagulation factor and gamma globulin during plasma exchange, which are not present in albumin replacement fluid. After exchange, the gamma globulin can be infused to prevent the infection. The plasma exchange in general is recommended for patients who have reached and are approaching the inability to walk unaided, who require intubation or demonstrated falling vital capacity, and who have weakness of bulbar musculature leading to dysphagia and aspiration. A French cooperative group on plasma exchange in GBS is beneficial, and two plasma exchange were more beneficial than none for time to onset of motor recovery among patients with mild GBS. Patients with moderate to severe GBS benefited from four exchanges. Those with severe GBS did not benefit any further with addition of two more uh, two more exchange. Because of its potential for inducing hypotension, patients who have compromise of their cardiovascular system or autonomic dysfunction may not tolerate this procedure. So plasma exchange is safe for pregnant women and children. For many years, plasma exchange was the gold standard for treatment of GBS, but in 1992, a large randomized trial performed by Dutch investigator demonstrated that treatment with the IVIG is at least as effective as plasma exchange and might be superior. A subsequent large randomized trial confirmed the equivalence of IVIG and plasma exchange, and in addition, there was no substantial benefit of using combination of plasma exchange followed by IVIG. So, in light of this study, the plasma exchange or IVIG may be used to treat GBS. Although both treatments are equally efficacious, the IVIG has become the preferred treatment because of its relative ease of administration. So, plasma exchange is not available in all centers and requires good venous access and stable cardiovascular system. In 3% to 12% of patients given IVIG, side effects may occur that range from minor reactions like flu-like symptoms, headache, nausea, malaise, to more severe side effects including anaphylactic reactions, transmission of Hep C, aseptic meningitis, and acute renal failure. Absolute contraindication to IVIG are unusual. For example, patient with IVIGA deficiency may be given IVIGA poor preparation with very careful monitoring and precautions. Then, individual with renal insufficiency must be given IVIG sucrose poor preparation with very close monitoring of their renal status and consultation with specialist in nephrology before insulation. American Academy of Neurology practice parameter recommended treatment with GBS who are unable to walk with either PE or IVIG. Treatment is beneficial if given within 4 weeks of onset of neuropathic symptom for plasma exchange or within 2 weeks of onset for IVIG. For those patients who are still ambulatory, plasma exchange may also be considered if given within 2 weeks of onset. Treatment with plasma exchange followed by IVIG is not recommended. Among about 10% of patients, spontaneous relapse occur within the days to weeks after initial improvement and stabilization with IVIG or plasma exchange, often among those treated early during their illness. This treatment-related fluctuation occurs within 8 weeks after initial treatment and occur with similar frequency with IVIG and plasma exchange. Presumably, the active disease phase lasts longer than the length of initial treatment. The retreatment with same therapy is commonly practiced, although the evidence-based literature is lacking regarding the efficacy of repeat treatment. Acute onset chronic inflammatory demyelinating polyneuropathy may be difficult to differentiate from GBS with TRF early on. Features suggestive of chronic inflammatory demyelinating polyneuropathy rather than GBS include deterioration after 8 weeks, the presence of 3 or more relapse, and the ability to walk unaided, and the lack of cranial nerve involvement. About 40 to 50% of GBS do not respond to IVIG and PE. So retreatment with same therapy also have been suggested for these patients who are severely affected and unresponsive to treatment, although there has been no evidence to support this. A recent double-blind randomized placebo-controlled trial of patients with GBS with poor prognosis found no benefit with second IVIG course and instead found increased risk of adverse event, including thromboembolic event and vascular event. Severe adverse event occurred in 51% given second dose compared to 23% given placebo. Thus, the retreatment with IVIG for those patients with severe GBS unresponsive to initial IVIG therapy is not supported at this time given the lack of benefit in potential arm. The combination therapy, that is plasma exchange followed by IVIG or IVIG followed by plasma exchange, has also not been found to be efficacious. In randomized control trial, the plasma exchange followed by IVIG was not superior to either treatment alone. Likewise, the small retrospective study found that IVIG followed by plasma exchange was not superior to IVIG. So the patient with combination therapy actually had longer hospitalization and worse disability grade, and perhaps because they had more severe disease course, conceivably because plasma exchange washes out IVIG and its therapeutic effect. Although it seems intuitively obvious that treatment of the GBS with corticosteroids should be beneficial, corticosteroids are ineffective and are not recommended in the treatment of GBS. So emerging therapy currently being investigated include complement inhibitor like eculizumab and C1q antibody, given finding from pathogenetic study suggesting the involvement of complement mediated nerve damage. In small phase 2 trial, more patients treated with eculizumab in combination with IVIG were able to run by week by 24 week than placebo group and secondary outcome measure. Finally, it is important to address the emotional need of the patient with GBS who will almost certainly be anxious, fearful, and depressed. Sometimes it is helpful for patient to speak with person who has recovered from GBS. Thank you a lot. Thanks, guys.